And good afternoon, good morning, good evening, depending on where you're joining us from. I will share the presentation. Great. So today, colleagues, friends in the ecosystem, today we are going to look at a very pertinent topic, which is health workforce in the continent. And these are precious, skilled hands that we have that take care of our mothers, our children, our grandparents. But there are challenges, and I believe in this room today we will learn together on how we can actually, have a thriving health workforce in the continent. To help us get through this, we will look at the presentation in this way. First of all, just setting the context. What's the landscape? What are those potential pathways that are out there? So we're going to learn both from within the continent and out of the continent. And after that, we shall engage my colleague Marilyn with on a fireside chat. And then after that, we are going to dive into questions and answers from this group. And then later, we shall also really have a call to action for all stakeholders. And so I'll just get started on just looking at the context of the health workforce in the continent. And we just bucketed this into various key things. There's so much to say about this area. But when you start in terms of just the quantity of healthcare workers in the continent, we see that there's 70% of African countries are actually facing critical shortages. And so this has made estimates about 5 to 6 million additional health workers will be needed by 2030. That's a lot. But there's also a paradox, which is famously called the African paradox. So where we have a higher number of healthcare workers than are being employed, but this is despite there being a very high need. So currently, only 31% of healthcare worker needs are being met, meaning a lot of people are out there skilled, nurses, doctors, physicians, lab technologists, but without employment. So 1 in every 3 graduates, colleagues, 1 in every 3 graduates risks not getting employment after graduating. A very worrying statistic indeed. Now, beyond that paradox, there's also maldistribution, because majority of healthcare workers prefer working in urban areas. And, the reasons are some valid and quite clear. Poor working conditions in rural areas. Some cannot access schools for their children. And so this is a phenomena that is dubbed the human capital flight, within the country. So we have a lot of people in the urban, a lot of concentration in urban areas, and very underutilized health facilities in rural areas because of the lack of healthcare workers there. Now, moving away from the numbers, the quality of training and curriculum. So we have various levels of medical schools, technical schools, but the infrastructure is still limited in terms of numbers, but also in terms of equipment. Some of these places still have hospitals training institutions that were built many years ago, less equipped, limited skilled instructors, and also the curriculum itself is very heterogeneous. So it makes the training varied, but also the quality to be suboptimal. And now the elephant in the room, financing, because it all boils down to financing. So overall, the financing for healthcare in the continent is below par because 21 African countries spend at least less than 5% of their GDP on health. So that's very, very minimal. And yet, according to evidence, 50% of healthcare budgets actually go into training and hiring healthcare workers. So it means if we are spending less on health, then we are definitely spending less on healthcare workers. But now again, on the flip side, as much as, yes, we talk about underfunding, it's important to also have an efficiency conversation, because 1 in every $5 spent on health is lost in technical inefficiency. That's worrying. 1 in every $5. So as much as we are having underfunding, we also have to have a conversation about efficient spending. And this means the inputs we are putting, we need to get the corresponding output. And in terms of health workforce, a lot of these things contribute to the technical inefficiency. Ghost workers on the payroll, I'm sure most of you can relate. You probably left one hospital a few years ago, and they probably still have you on payroll. Absenteeism, suboptimal performance, all these contribute to the technical inefficiency. Now, on the demand side of things, there is really poor working conditions, proper tools, equipments, low salaries, long hours, limited career progression. And lastly, a very big challenge that the continent is also facing, which is the immigration or the brain drain. 1 in every 5 African-born physicians is working in a high-income country. So these are people we've trained, our brothers and sisters, but because of these challenges, they have found opportunities elsewhere. And this actually is costing us a lot of money, to the tune of 15 billion in lost economic growth. So this is something that we really need to think about. And so that's the context that we are operating in. So it means then this is a critical issue that we need to address. And what's the rationale then of even looking at the health workforce more critically? I think there are 2 major buckets. One, on one hand, we have growing and complex healthcare needs in Africa. If it is not having the largest global disease burden to the tune of 25%, but yet only we have 4% of global health workforce, challenging health situations and diseases every 6 seconds. By the time we finish this meeting, we will be able to calculate, unfortunately, how many children have died before their 5th birthday due to preventable diseases like diarrhea, malaria, and pneumonia. And now we've seen COVID, and a lot more frequent and deadlier zoonotic diseases and spillovers are actually going to quadruple by the time we are hitting 2050. Now, not even mentioning NCDs that are on the rise. So it means in terms of growing complex health issues, climate change that's going to buttress even more pressure on the healthcare system is one end of the continuum. On the other flip side, the economic and disease burden impact of not having proper healthcare workforce and health issues dealt with. But because it has shown, if you improve health, right, it does not only improve global health security, but it actually stimulates economic growth. And so if we close this shortage, according to evidence, 7% of global disease burden can add $1.1 trillion into the global economy. And even a much larger economic stimulus comes from healthcare workers being able to enable a healthier, more productive workforce. So you gain economic impact there, but they're also able to catalyze indirect non-healthcare jobs as they get employment. So the rationale and the investment case is very clear. And so with that context, and looking at the rationale why we should actually look at healthcare workforce and why we should invest in healthcare workforce, what then are the potential pathways towards a thriving workforce? And I borrowed this from a paper that's yet to be published, and Marilyn will tell us a bit more about that, by McKinsey. And I liked this healthcare workforce triangle because it really is a nice conceptual framework to think about some of the solutions or pathways towards solving some of these challenges that we have highlighted. So grow, thrive, and stay. How do we make our workforce to grow? How do we make our workforce to thrive? And how do we make our workforce to stay, to be retained within the continent? So when you look at growth, it means one, as much as yes, we have that paradox of higher number versus absorption, they still need to expand a pipeline. And so that means we need to reimagine our training programs. There are papers and evidence out there of virtual reality in nurses training that has made significant impact. Some countries reducing the number of years it takes to do some of these trainings just to make sure that they're channeling out enough pipeline to fill the gaps. Two, reducing the barriers to entry, because getting into some of these schools, medical school, nursing schools, is really a barrier for most people, whether it's in terms of the grades, the school fees, and all those challenges. And then, of course, the training curriculum. And I know we have a lot of colleagues here from the academia. We would love to learn from you. The training curriculum, it's still it hasn't evolved, to meet the need in most cases. It's not standardized. And so if it can be redone and re-looked into in a way that is demand-driven considerations are made, and also the future of work, because the kind of nurse or doctor or pharmacist needed for the future may not be what we are training right now. So those are in terms of growing these healthcare professionals. The second bucket is about how do we make it a thriving profession, right? So one, of course, we need increased funding allocation. That one cannot go without saying. And these sources have to be from domestic resources from our governments. There's opportunities in private sector and also opportunity in innovative financing mechanisms. Could we have social impact bonds on healthcare workers? Could we have taxes, sin taxes, for example, that countries collect and ring fence that to actually pay salaries for their healthcare workers, for example. Number two is leverage technology. How can we automate some of these tasks so that we free up time for me as a nurse or as a doctor to do what really I'm called to do, which is to take care of the patient. And we've seen up to 15%, according to evidence, of nurses' tasks could actually be automated through AI. Filling all those codexes, documenting and doing all that. We really free up the time for nurses and allow them to thrive in their profession. And lastly, task shifting, which is really gaining momentum, but it should be evidence-based and well-planned to ensure efficient service delivery. And lastly, how do we make them stay? Yes, we've grown the pipeline. Yes, we have the numbers. We are investing in them to be able to thrive. But are they staying? Or is it investing and they go away? So one of the ways and one of the pathways is we have to invest in better working conditions, because we cannot look at the healthcare worker as an individual. They function in an ecosystem. They function in a facility. How is that facility? Is there fair compensation? Are our facilities equipped? Do we have opportunities like digitization of care? And we have examples which we will look at shortly, where some of these countries are doing that and they've had very good retention rates. Number two is address key pain points. You would be surprised, colleagues, the amount of violence that healthcare workers face in the ER, in the clinics. 1 in 4 healthcare workers globally faces either physical or verbal abuse. And so some of these pain points should not be happening and should be addressed to make sure that we have retention. And then invest in talent localization. We saw the human capital flight. How do we make sure that we deal with brain drain and we actually make them stay? We are going to look at some of the examples that some countries are doing. And lastly, being able to harness the full potential of migration. And recently in 2024, WHO published bilateral agreements on health worker migration mobility, a guidance for governments to be able to actually get into agreements, both with the host government and the country that is taking these healthcare workers, to make sure that it's a win-win situation and not a situation where, one country benefits. You just come, take healthcare workers, leave our country, with shortages and gaps, and not even invest or support in making the healthcare system better. So to manage that, WHO has come up with a very good guidance, and so it's been published just last year. So this is the framework, and so some examples of some countries that are actually implementing some of these pathways or potential solutions. In terms of grow, we have a good example from Brazil, where they they increased their pipeline. They added their medical school. In 4 years, they opened 70 of them, were able to train 35,000 new physicians, and that increased PHC, primary healthcare access, by 10%. Similar to the US, they decided to reduce the training duration. Of course, that has to be evidence-based. It has to look at the curriculum and the way, to ensure that quality is not compromised. But they were able to achieve that, and they were getting 10,000 nurses graduating every year. Closer home in Rwanda, we have the University of Global Health Equity as well, enabling 85% job placement and pathway to quadruple their workforce by 2028. Examples of how other places are helping our healthcare workers to thrive is in the UK. They have managed to reduce their consultation time by 26% while maintaining the patient interaction through AI-assisted clinical documentation. And I know we have a lot of young people here. These are some of the innovations that we can actually bring, into our ecosystem, into our countries, to be able to solve some of these problems. Another example, closer home, Malawi. They have a tool that can actually can read the x-rays and be able to diagnose TB from 11 days that it takes to do the interpretation to 1 day, and yet with an accuracy of about 91%. So it frees up physician time to actually provide the care. Similarly, in India, task shifting, community health workers were able to to go into the communities, get the diabetes patients, early detection, bring them there. And this has reduced unnecessary physician visits by 1.5%, by 1.5 times. And in terms of staying, we have also country examples. One, France reduced the workplace violence in emergency department by 53% in 1 month by putting some of this computerized triaging in the facilities. A good example that I really liked is implementing the rural recruitment program in Thailand. So Thailand had the maldistribution challenge where a lot of their physicians were only based in the urban centers. So one, they did, they put a policy that there is a 1-year mandatory service in the rural clinic. So before you specialize, you have to have done 1 year at least and minimum in a rural facility. Number two, they went ahead and constructed medical facilities in rural areas in Thailand. And so what that did is that the doctors and physicians who studied there naturally, went to work in the rural health facilities, and they had a retention rate. 2/3 of those doctors were actually retained for more than 5 years in the rural area. Number three, they also incentivized them by saying, if you work in the rural area for 3 years, you get a scholarship to do your specialization. So these are some of the things that countries are trying to solve some of those challenges that we have seen that are so rampant. And lastly, a very good example of supporting, brain drain was happening in India, in Indonesia, Tunisia, and the Philippines. And German, on the other hand, had shortage of nurses. So they came up with this triple win program. It's about 10 years old, and it has been quite successful. And it actually follows some of the principles that WHO has proposed on mutually beneficial bilateral agreements between governments. So one, they select countries where there's no shortage, right? So it means there is this unemployed, they're trained but unemployed, and they take them on board. They train them in German language, they certify them, they ensure they are integrated, they pay them well, they are able to repatriate some of those earnings back to their countries. There's also opportunities for circular migration for those who would want to transition back. And this has been a very good example of what a win-win kind of migration can be, because the truth is, you can't really stop people from going, right? So I think the best thing would be, how can this be more structured? How can this be more organized? Nigeria, for example, did publish and approve a policy, again, also on healthcare worker migration. And it is entrenching some of these principles to just make sure that there's a win-win, that there is investment back into their healthcare system, into their trainings. So then it's not just a brain drain, but there is earnings from that opportunity. So then with this, ladies and gentlemen, what are those bold actions that we can really take to transform the healthcare workforce landscape in the continent? I think one, we need radical shifts, generating evidence to change and track progress. So we can test some of these priority initiatives. And then once we see the evidence, we then support wide-scale adoption. Number two is shifting human resources for health policies to align with evidence. I think we cannot overemphasize the need for evidence-based policies so that our decision makers are able to actually plan budget based on evidence, right? And revising even the existing policies and institute new human resources for health policies to make sure that we are addressing these gaps, and also that we are able to, look at those new opportunities like task shifting and be able to implement those. Number three is provide catalytic funding for sustainable scaling and implementation of these shifts. I think funding, we have to rethink this. We are cognizant of the shrinking fiscal spaces in our countries. We are cognizant that the donor funding is also dwindling. So then we need to be very innovative in how we plan for our human resources for health, but also how we fund this, because it's something we cannot do without. And so we need to develop a funding strategy with a very clear return on investment to be able to make this argument with our ministries of finance, for example, and also mobilize resources and partnerships and think outside the box in terms of more innovative financing mechanisms that I had mentioned earlier. And the second last thing is drive implementation and implementation excellence. So the tools and processes, AI, capabilities in managing these HRH interventions, ramp up implementation planning and capacity building, effectively within our ministries of health, within coordinating policymakers, within our partners and implementing organizations as well. And then, of course, we need to champion these big shifts through coordination and collaboration. I don't think there's one government that can do this alone. There is no one single organization that can do this alone. It will require a lot of collaboration between governments, private sector, non-government organizations to really make this a reality, secure the political buy-in, coordinate the resources, and being able to solve some of these challenges. So the call to action, in a nutshell, to policymakers, we need to lead the way with data, with evidence, and with creating policies that actually match and are able to solve some of these challenges. For example, enabling accredited online-led programs. Long time ago, when you say you've done a course online, it looks like it was almost not as good quality or you're not as qualified. But I think the world has changed. And so we need to really move with these shifts and actually adopt them. And to academia, we need to refine this curriculum, right? Are we producing nurses that are relevant, globally relevant? Are we producing nurses that are also relevant in our countries? So let the curriculum really reflect the need and best principles, and let it even be standardized so that even if I practice in Rwanda or in Kenya, that qualification should be recognized. So there's a lot of work to do there and unlock those cross-country opportunities. And to the funders, allow and provide funding for innovation to support some of these financing mechanisms and scaling of solutions. And private sector, as a driver of innovation, there's so much in terms of technology-enabled training solutions, virtual reality, AI-driven solutions. The ground is open for that. And of course, to the implementers who make this work, I think rethinking trainings, rethinking resources, and being able to incorporate this new way of doing things into the new and existing programs. So I'll pause there. Thank you very much.